Hello, my name is Eric Bailey. I'm the Director of Organizational Development at the CORE Institute, and I'm also in the Masters of Leadership and Organizational Development program at St. Louis University. Today I'm going to share with you my proposal for a research study that I'm going to conduct called Behavioral Scripting and Patient Satisfaction. First, I want to share with you my abstract. Here are some of the things that we're going to talk about during this presentation. We're going to start with some definitions, then we're going to go into the research question and my hypotheses. Then we're going to go into literature review and methodologies, and finally into results. So, first, some definitions. Patient satisfaction is a term that's used in the healthcare field that's used to measure how patients react to our healthcare. And it's typically a score that's given based on a survey. The problem is when it's a score, it's typically compared against other organizations or other things. When you do that, you have a competition. And when you look at a competition, according to a study by Gluckensberg in 1962, you have extrinsic motivation. And in his study, he looked at the effects of extrinsic motivation on complex problems as opposed to intrinsic motivation. And he found that when you have a complex problem and you introduce an extrinsic motivator, you're actually less able to think creatively. So when you think about patient satisfaction as a number or a score as part of a competition, patient satisfaction improvement is a very difficult, complex problem. So introducing a extrinsic motivator actually decreases the ability to solve the problem. So what I want to do for this and during the study is look at a different definition, actually a pair of definitions from Merriam-Webster's dictionary, and I want to break it up into patient and into satisfaction. The definition of patient is someone who receives health care, and the definition of satisfaction is someone who feels good or feels happy based on something they've done or something that's been done to them. So when you look at patient satisfaction, we're actually talking about someone who receives our health care and feels happy because of it. So when you think about that, if the goal is patient satisfaction, if the goal is making someone happy by giving them health care, then we have an intrinsic motivator. Another thing I want to talk about is I want to define the CORE Institute, and I'll give some background on the CORE Institute. The CORE Institute is the largest orthopedic practice in Arizona, and actually recently just acquired a neurology practice, so now it's the largest orthopedic and neurology practice in the state of Arizona. The CORE Institute is also in the state of Michigan, in Detroit, Southfield, Novi, and soon opening up offices in Grand Blanc and in Brighton. So what makes the CORE Institute different than other orthopedic practices is we practice evidence-based medicine. We have an integrated research lab which identifies which procedures, which devices, which rehab works best for our patients, and then we propagate that through standard order sets across the entire populace of physicians and physician assistants. So, unlike other orthopedic practices, we do the best thing based on the research, and everyone that does, let's say, a total knee surgery does it exactly the same way. So we practice evidence-based medicine. So when I looked at this, I wanted to figure out what can we do? What can we do with that tenet of evidence-based medicine and improve our patient satisfaction? And so the research question, does the implementation of scripted behaviors for front office, medical assistants, radiology technicians, and orthopedic technicians positively affect patient satisfaction scores and patient experience? My hypotheses are this. I hypothesize, one, that proper behavioral scripting, when adopted by the entire clinic, will remove variation in the perceived quality of care and improve patient satisfaction scores. Additionally, I hypothesize that improved patient satisfaction with clinical operations will result. Additionally, I hypothesize that improved patient satisfaction within clinical operations will result in improved patient satisfaction with physicians and physician assistants. All right, let's get started with my literature review. I reviewed 4 articles that deal with patient satisfaction, communication, smiling, experience, etc. And I wanted to identify where the gap is in the research. And I found some fantastic articles I want to share with you. The first one, which is most closely related to my study, is called Script Usage in Standardized and Customized Service Encounters, Implications for Perceived Service Quality. Now, this article, this study, looks at the hospitality industry, hotels specifically. And to identify what a standardized and customized service encounter is, you'd think that the front desk of a hotel is a standardized service encounter. The front desk agent is doing the same thing over and over, checking people in, getting people new room keys, getting people whatever they need, that sort of thing. Standardized. They're doing the same thing over and over again. Same at a hotel, you look at the concierge. They're more of a customized service encounter because most every person that goes to them is going to have a different question, have a different need, and so they have to give a service encounter that's unique. It's customized per person. So what the study looked at is if you give scripting, hard, fast scripting to people at the front desk and to people at the concierge desk, how do patients perceive the service quality? And what the study decided, or what the study discovered, is that folks in a customized service encounter perceived the service quality less when there was a hard, fast script. People in a standardized service encounter, when they had a standardized script, they perceived the service quality just fine. There was no dip in service quality perception. Now, where the study falls short is the script usage deals entirely with spoken verbal scripts. It has nothing to do with behavioral scripting. So if someone is to hold the door, or if someone is to bow, let's say, those are behaviors. Behaviors are things we do. This study stops short of that. Additionally, I think there's a gap in this study because it doesn't identify the variation or the gradation between standardized service encounters and customized service encounters. You'd think that a valet at a hotel has a very routine thing. They're doing the same thing over and over again, but as they interact with people, they have to customize their behavior. They have to run. They have to run and grab keys. They have to deal with people differently. They have to answer questions. They have to give directions, etc. So this study does not allow for any gradation between standardized and customized. So that's another thing I wanted to look out for. The second study is a really wonderful study done by one of the leading researchers of the placebo effect. His name is Ted Kaptchuk. And what he did is he was looking at what's called now as the caring effect. So again, he's a lead researcher in the placebo effect. So what he did is he took about 127 people who have irritable bowel syndrome, and he broke them up into three study groups. The first group, he said, okay, we have a new method to cure your symptoms for irritable bowel syndrome. However, group one, you're on the waiting list. Okay, that's the control group. The people that improve are people that would have improved anyway. Right? The second group is the placebo group. And what he did was he engineered fake acupuncture needles. And he said, we have a wonderful new method to treat your symptoms. It's called acupuncture. Group B, you're going to come in and you're going to receive acupuncture. Now, what he didn't tell them is that the practitioner has zero extra. He's not giving anything more. He's coming in, he's doing the procedure, and he's walking out. He's not giving extra conversation. He's not giving extra caring. The third group got the same exact procedure. However, the care provider spent a lot longer, an extra 5 minutes, 10 minutes with the people, answering their question, explaining what this needle does, what that needle does, explaining to them what benefits they're going to get from acupuncture. Just being warm and caring. He used healing touch. He used all these wonderful things that make you feel good about a care provider. So again, no actual intervention was being done other than a fake acupuncture and a warm, caring provider. Well, the results were astonishing. Over nearly 40% of the people in the latter group saw a reduction in symptoms. Again, no actual intervention was done. So this leads to the idea that caring matters. Dealing with people in a warm environment matters. Another one is identifying the links between smiling and stress. It's called Grin and Bear It, The Influence of Manipulated Facial Expression on the Stress Response. And this is difficult to explain, but I want you, as you're listening to this presentation, watching this presentation, take the tip of your index finger and put it between your lips, like you're holding a pen or something. The index finger is a pen. Hold it between your lips. And if you can feel what your face is doing, you're not holding it tight, just kind of letting it rest in there, and your face is totally relaxed. That's called the natural smile. Neutral smile, excuse me. Now, take your same fingertip, and instead of holding it between your lips, hold it between your teeth. And when you hold it between your teeth, you can feel that the cheek muscles are contracted. So if you were to look at yourself in a mirror while you do that, you actually have a smile on your face, holding it between your teeth. Now, the third type of smile, that's called the standard smile. The third type of smile is called the genuine smile. And if you take your finger, instead of holding the tip between your front teeth, you turn your finger sideways and you stick your finger, and I'm going to do it so you're going to hear my voice get a little funny. You stick your finger all the way in, so you're biting down on your finger like this, and if you look at yourself in the mirror, not only are your cheek muscles contracted, but also the muscles around your eyes. That is the same expression you give when you give a genuine smile, a Julia Roberts smile. So what this study did is they looked at a lot of people in these different smile types, these forced facial expressions, manipulated facial expressions, and people that had the genuine smile actually responded to stressful situations better. It's absolutely amazing. So the reason I have this study is people who come into orthopedic clinics are stressed. And if we can give them a better way to respond to this stressful situation, we can improve their experience. The final study that I looked at is really interesting. It talks about physicians' communication style and patient satisfaction. And the two physician communication styles that it looked at was controlling and affiliative. So if you think about a controlling physician communication style, that's someone who's going in and trying to dominate the conversation by asking questions, re-asking questions, not let questions be asked of them, forcing it down a path, steering the timeline, etc. You've been in a communication style like that. And when it's like that, it gets really difficult because the final study that I'm looking at is called Physicians' Communication Style and Patient Satisfaction. Now what this is looking at is two distinct communication style. One is controlling and one is affiliative. Now if you think about a controlling communication style, that's someone that's driving the conversation where they want it to go. They're not letting you get a word in edgewise. If you have a question, they're going to continue bulldozing over you. Right? We've all experienced people like that, not necessarily physicians, but we know what it's like to be dominated in a conversation. Now the other communication style is affiliative, and you think about affiliative, when you're affiliating with someone, you're being on the same page, you're getting to know them, you're understanding them. And a physician who has an affiliative communication style is one that's going to listen to you, is going to ask you questions, trying to understand where you are so that you can be on the same page. Now, it's very obvious that a physician who has an affiliative communication style is going to have higher patient satisfaction because the patients feel like they understand a lot more. And that's what the research found. So as I develop this study and as we develop our scripts for behavior, we're going to be implementing all of these different studies into them. However, I do feel like there is room for my study in this space. I think that adding behavioral scripting, I think that looking at everything we're looking at, we can find a space for this study, and I think it's needed. So looking at the methodology, first things first, we need to identify what the behavioral scripts are going to be. So we've identified a group of people that we're going to call the change champions or the change team, and we're meeting with them on a weekly basis. So these are medical assistants, radiology techs, everyone that's going to be assessed in this process. They have an opportunity to be a part of creating this process. So we have behavioral scripts that we're trying. We have behavioral scripts that this team is generating. So at the beginning of each meeting, we have a questionnaire for each script that we're talking about for that meeting. Some of the questions from the questionnaire: on a scale of 1 to 10, how completely did you commit your behaviors to the script? This will give us an idea of A, who's invested, and B, how likely is it that the rest of the team across the clinic will commit themselves to the behavior. 6, on a scale of 1 to 10, how effective at improving the experience of our patients was this script? And do you recommend that we continue the use of the script? Now, these questions, we're trying to get the feeling of the change champions, the people who are doing the work, the people who are generating the ideas. And we're coming up with tons of qualitative data, and we're not just a bunch of executives or a bunch of researchers coming up with random questions. These are medical assistants who are thinking, here's the best way to do this thing. All right, now as far as the quantitative, we're using a data collection process that already exists. The Core Institute has partnered with Press Ganey, and actually Press Ganey is a third-party company. And Press Ganey looks at a ton of data. So it's a really wonderful process, and what we do is every day we look at the previous day's patient load, and we look at every patient that has a valid email address, and we run a report. This is a little sample of the report. I'm not going to show you any more for HIPAA purposes, patient protection purposes. But we scrape every patient that visited the day prior, and then we put it into a chart, and we publish that information to Press Ganey. We push it to Press Ganey. What they do then is they generate an electronic survey, and they send it out to all the patients. So every single day we're pushing out 400 to 1,000 surveys to all of the patients that visit us. So we've been doing this for 3 years now, so we have tons and tons of data. This system is set up, it's established, it's going before the survey, before the study, and afterwards. And what the patients are getting is they're getting an email. This is obviously a sample. You recently visited the Core Institute, we need your feedback, etc. It's signed by a chairman and CEO. The patients get this in their email box, they click the link, and they can take the 38-question survey. Now, how do we measure reliability and validity in my study? Well, as I said before, we've been doing this Press Ganey patient satisfaction survey for 3 years now, 3 complete years this December. 3 complete years. So we have a lot of data. So what we want to do is we want to look at the 38 questions, and we're going to subtract out the 12 questions that we're going to be using for my study. And I'll explain those in a little bit. So we have 26. Now, 26 questions left that are not part of this current study on behavioral scripting. Out of the original 38, that's 68%. So 68% of the survey that goes out on a daily basis does not touch the study. What we can do then is we can compare that to the previous 3 years of data, and if the questions and the answers to those questions that should not be touched by the survey, the study that I'm doing, if those are in line, then we know that we have a reliable study. Now, as far as validity goes, I'm going to compare my data on scripting to the data pulled out from the script usage, the first in my research, my literature review, script usage and standardized and customized service encounters. Now, that is established research. I compare my data to their data and look for correlations. Now, my results. Now, first of all, I want to look at, here are the 12 questions that I'm going to be using. Now, of the 38 questions, these are pulled from all the different categories: courtesy of registration staff, information about delays, friendliness and courtesy of the nurse or medical assistant in this case, concern the medical assistant had for my problem, our sensitivity to patients' needs, the staff worked well together, likelihood of recommending the practice, courtesy of radiology technologist, radiology staff concerned for comfort, radiology staff sensitive to pain, courtesy of cast technician and understanding the cast at home care. Now, the data that we're getting back, and this is a sample of the data that we're going to be able to get back. We're going to get a frequency analysis. Our survey comes back with each question scored on a 5-point Likert scale. So patients can say we were very poor, poor, fair, good, or very good at each one of these questions. And Press Ganey allows us to see per question, what percentage of people said we're poor, fair, good, or very good. We can also see, if we want to, just the raw sample score there. This number here is a sample size of the number of people that answered the question. Now this is just an example. This is from January through current, so you can see there's a lot of data in here. Now as we do this is a special report that is run in addition to the regular report that runs all 38 questions. So we can see how we're doing on a day-to-day, month-to-month, quarter-to-quarter basis. Now on this slide, this is another version of a different survey, or different questions pulled out of the survey scored differently. You can see percentile ranks as compared to all facilities that are scored by Press Ganey. There's some 12,000 different facilities. You can see, based on orthopedic practices, how, in this example, how this care provider scored as far as a rank compared to all other orthopedic physicians, and how they rank based on facilities that have 40 to 60 healthcare providers. So back to this. Our results. We're going to be able to track the results through Press Ganey. We're able to track correlations. We're able to track mean differences in the scores. We're able to track frequency analysis. At which percentage of people are saying we're good versus very good before the study sample dates and after. We can identify a lot of key information through this data. Now, one thing I want to talk about is I want to disclose that my name is Eric Bailey. I'm the Director of Organizational Development, which means I am paid by the Core Institute. And part of my role, part of my essential duties, is to track and improve patient satisfaction. So it's very likely that I will be reimbursed by the Core Institute if the patient satisfaction scores improve. Now, I have several different things I want to say that protect against bias in this situation. First and foremost, this survey has been going out to patients for the previous 3 years. There is a lot of data on what the numbers should be. Additionally, patients who are going to be participating in the study do not know that they're participating in anything different than the regular study that's been going on for years. So their survey is not going to be different. It's not going to be manipulated. There's no way to pull out certain people to modify and manipulate the scores. Additionally, we have high transparency in this. We have purchased unlimited licenses, so any member of the Core Institute organization can look at the data and can see what's going on. So, also, additionally, the medical assistants who are part of the champion team do not know that we're doing this study. They know they're part of a champion team. They know that their mission is to improve patient satisfaction. They don't know that the study exists. They don't know that what's going on. They think that the surveys that they're filling out are to improve satisfaction, not necessarily to give us qualitative data for our study. So there's a lot of safeguards that we've built in because I am a practitioner researcher, because I am paid by the Core Institute. But I wanted to identify that. So as I propose this research study, I think that there's a need for it out in the academic literature. I think that it's going to produce, during the process, we're going to produce a better experience for our patients, which is a tremendous motivator for me and for the Core Institute. I think that there's a lot of opportunity to get rich data. I think there's a lot of opportunity to find things that we didn't know existed. So I hope that you consider my research proposal. I hope that you can see the value in it. And if you have any questions, please feel free to contact me at ericbailey@thecoreinstitute.com. Thank you very much.